My thesis topic is functional vision assessment in children with global developmental delay coming to a tertiary care center. So vision loss early in life has profound functional and psychological implications. So vision impairment is known to occur in children with multiple disabilities. Hence, instead of doing only a conventional vision assessment in these children, we must also perform a functional vision assessment. So functional vision is defined as vision that can be used to perform a task or task which requires vision. That is how a person uses vision in his daily life. The information gathered from FEA is often quite different from what we see from CVA, and normal visual acuity doesn't necessarily imply a healthy visual system. So need for the study, goal of FEA is to determine what and how the child sees and what can be done to best facilitate learning through the visual sense. So identifying the range of visual limitations and strengths through FEA can help to plan early intervention programs and integrate with the multidisciplinary therapies. So just to see the difference between visual function and functional vision. So examples of typical visual functioning system includes visual acuity, field, contrast, color vision, etc. But in functional vision, we see the orientation and mobility, daily living skills, communication and sustained near activities. So in typical CVA, it will be each eye separately, but in FVA, the fourth will be measuring for the person as a whole. And method will be variable stimulus with a fixed threshold performance in the conventional assessment, and in FVA it is a standardized task, variable performance or with difficulty. So test will be single variable under control conditions and the other will be multiple variables. Coming to aim, primary aim is to assess functional vision in children with global developmental delay, and secondary aim was to correlate functional vision with the severity of disability and also with the conventional visual acuity. Inclusion criteria, GDD, children from 6 months to 5 years were included. Exclusion, any primary ocular disorders like cataract, congenital cataract, glaucoma, vision threatening ROP, retinal conditions all were excluded. Study design, cross-sectional observational study. Methodology, children in the age group of 6 months to 5 years. Diagnosed with GDD, we refer to ophthalmic evaluation, detailed birth and perinatal history noted, and ophthalmic evaluation done in 2 stages, that is conventional and functional. During our first visit, visual acuity was assessed using both qualitative and quantitative tests. And children were then called for us. Also we did the contrast sensitivity, ocular motility and nystagmus, anterior segment examination, refraction and fundoscopy, and glass prescription was given based on AAO guideline. Second time the children were called for the functional vision assessment. So the following components were noted: visual attention, vision for orientation and mobility, vision for communication, cognitive vision. Our scoring was based on the visual function classification system, which had 5 scales. So GDD children were categorized based on the development quotient. So statistical analysis was done using chi-square and man-Whitney test, and a p-value of less than 0.05 was considered as significant. So results include we had our age range was 2, interquartile range with 1 to 4 years, 66.7% were males, and we found different associations of the global development delay, and etiology birth asphyxia is the most common cause in our study, and MRI findings, hypoxic ischemic encephalopathy or PVL findings were more common with the severity of GDD. Ocular diagnoses were categorized, and mean visual acuity and other typical vision function was noted. Also functional vision variables were noted. So functional vision showed significant correlation with the conventional vision. Severity of GDD was correlating with the vision impairment, and there was also significant association between presence of microcephaly and seizures with the vision impairment. These are the limitations of my study, and conclusion, FEA is a valuable tool which can help us to understand how the child uses vision in various day-to-day tasks. Thank you.
For your visual field, when the child is suboptimally cannot understand, how do you prevent him from looking towards the I mean, it's very difficult to manage a visual field in such children because you have to keep looking hardly any, I mean, I don't know how he did it. So
Yeah,
how
we
did you
gave
do
a
it? I have a
stimulus,
special
ma'am.
child, I want to know. So I have never been able to do it for my child.
Ma'am, illuminated toys, something like that.
No, but the child will look towards that, right?
No, ma'am, we centered this, maintained the fixation with the illuminated toy. So the child will be looking at that direction, ma'am.
But non-verbal children cannot.
Even non-verbal children, ma'am. When we showed the illuminated toys, the child tend to look into that direction and fixate in the
Did you
direction.
reduce the size and the intensity?
No, ma'am, like a standard size was noted. But some children
Because the
responded
peripheral
to,
retina will have more vision than the central. So you cannot use the same size objects for the central and the peripheral.
no, ma'am, periphery we used a little bit smaller ones
I
compared
think
to
you
the,
should document what you actually did rather than theoretical for us to hear it.
Video would have helped, yeah, probably. But I think 4 minutes, that makes it less.
Pieces, yeah.
Yeah.
This must be your thesis topic, no? So you are actively participating in this. So have you mentioned the causes of GDD in your list?
yes, sir. We had classified the causes. So birth asphyxia came to
Use
be
the mic. Yeah.
birth asphyxia came to be the most common cause, sir. So MRI features also showed the same. Hypoxic ischemic encephalopathy, periventricular leukomalacia was common cause for the GDD.
Did you apply any retinoscopy in any patient, your patient?
Yes, sure, sir. We did a dynamic where possible and also after dilated retinoscopy also.
Also, okay. So how many patients having a visual problem in your study?
Sir, refractive errors, sir.
Yeah. Which
Sir,
type of refractive error and how will you improve the refractive errors this in your study?
we studied about the refractive error, like it was not classified. We didn't correlate the type of refractive error as such. And
Is there any squint of the any patients you study?
yes, sir. Strabismus was also noted.
Then you have to do full correction after retinoscopy. You know.
Should we go to the next?
Thank you.
Dr. Harsha, are you here? And after Dr.